This video is on diabetic ketoacidosis, short form DKA. So DKA is caused by an absolute or relative decrease in the insulin levels, and that's why it's more commonly seen in type 1 diabetes mellitus. This is the diagnostic criteria to diagnose DKA. First one is hyperglycemia, where the capillary blood glucose is more than 11 millimole per liter. Second is metabolic acidosis. Third is ketonuria, which means there's ketone found in the urine. Diagnosed when the urine ketone is plus 3 and above. These are the few causes of DKA. First one is idiopathic, which is quite common, 40% of the cases. Infections like urinary tract infection or upper respiratory tract infection can also cause DKA. Insulin errors, for example, if the patient is a diabetic patient on insulin injections and then they miss the therapy, or there is significant reduce in the dosage. And the fourth cause is infarction, for example, in patients with heart attack, acute myocardial infarction, or stroke events. So how does DKA occur? This is the pathogenesis. So when there is absolute insulin deficit, there will be lack of insulin to suppress the lipolysis process. And because the body will need energy, they will start producing energy from the triglycerides. So this will release fatty acids from their adipose tissue. And when there is hydrolysis of fatty acids in the liver, also known as ketogenesis, there is formation of the acetyl-CoA and ketone bodies. So these ketone bodies will become excessive and it will cause ketonuria, which is ketone in the urine, and also cause metabolic acidosis. The clinical features of diabetic ketoacidosis symptoms include hyperglycemic symptoms like polyuria, where the patient urinate a lot of times, polydipsia, they are very thirsty, and also loss of weight. Gastrointestinal symptoms include nausea, vomiting, and abdominal pain. Dehydration symptoms, for example, they feel posterior giddiness, they feel dizzy when they suddenly stand up from sitting, or they feel weakness in their limbs. And also metabolic acidosis will cause altered mental status, where they will be confused about their surroundings. Signs, we can assess the level of consciousness using the GCS score, usually reduced in DKA. And other sign, a significant sign is Kussmaul breathing. It happens due to metabolic acidosis and the patient is trying to blow off carbon dioxide, trying to reduce the acidosis. Ketone breath and signs of dehydration like sunken eye, reduced skin turgor, dry tongue, and check the blood pressure, it will be hypotension. So the investigations to diagnose DKA. To confirm the diagnosis, we have to do plasma glucose, urinary and serum ketones, and also arterial blood gas analysis to check for metabolic acidosis. To assess the severity, we can do blood urea and serum electrolytes and also creatinine level to assess level of dehydration, assess the electrolyte abnormalities, the glucose, can also assess the calcium, magnesium, phosphate levels. To check for the underlying etiology, we do ECG and cardiac enzymes to rule out acute myocardial infarction causing DKA. Do chest x-ray to rule out pneumonia, which is one of the URTI. Full blood count, check for leukocytosis and also increase hematocrit levels. Blood culture and sensitivity if the patient looks septic. And UFIM and urine culture and sensitivity is to rule out UTI. So the principle of management is these 5 things listed over here. To prevent further dehydration, we have to give water and sodium replacement. Secondly is the potassium replacement to prevent hypokalemia. We also correct the acid-base imbalance to reduce the metabolic acidosis. We give insulin, and also insulin is to reduce the hyperglycemia and also prevent the treatment complications, which I will talk about it later. Let's look at some of the complications of diabetic ketoacidosis. So it will cause fluid, electrolyte, and acid-base disturbance. It can also cause congestive cardiac failure and also acute renal failure. So there are some complications from the treatments as well. For example, cerebral edema, which actually cause a high mortality rate in child and adolescent cases. So how does this cerebral edema occur? It is due to over rapid correction of the fluid, rapid correction of the hyperglycemia. So cerebral edema will present as the child will be irritable and also drop in the GCS score. And if late presentation, they will have raised intracranial pressure. It usually occurs 6 to 12 hours after the DKA treatment. And the management is to elevate the head of the bed, intubate and hyperventilate the child, and also give intravenous mannitol. So other treatment complications include hypoglycemia, hypokalemia, due to influx of the potassium ions into the cells from the insulin effect, and also hypophosphatemia. So that's all for this video. Thank you.